Hello, I'm Dr. Noelle Cloven. I'm a gynecologic oncologist with Texas Oncology in Fort Worth, and I'm also the co-chair of the Communications Committee for GOG Foundation. I'm honored to introduce my colleague who's played a pivotal role in shaping clinical research for recurrent cervical cancer. Her leadership in designing and leading clinical trials has moved all of our promising therapies from dream to reality. Her work continues to influence the standard of care and give hope to patients worldwide. Dr. Randall, will you please introduce yourself?
Oh, hello, everyone. And thanks, Noelle. That's a great introduction. I really appreciate that. I'm Leslie Randall. I am also a GYN oncologist. I practice at the Inova Shar Cancer Institute and the Inova Health System. We're in Northern Virginia, which is really close to Washington, D.C. We have a huge, diverse population up here. Really happy to be both in my institution and here to talk to you about all this progress today. Thanks for the shout out. I provide a support role. I provide air cover to everyone doing all this really hard work. So just really happy to talk about it today.
Thank you so much. So, we're here today to talk about GOG 3101, otherwise known as the TroFuse-20 trial, which is a trial for recurrent metastatic cervical cancer after chemotherapy and radiation. And I'd like to start with a little bit of background. And I know you've lived this. This has been your life. So, if you wouldn't mind just starting and telling us a little bit about how more of our recent clinical trials have really shaped the current standard of care and improved outcomes for patients with metastatic cervical cancer.
Yeah, I'm happy to. I think there are two ways of looking at this, right? I mean, you can look at the academic piece and look at all the work that's been done in cervical cancer, much of it by this group, by people watching this podcast. It's been a huge shift in survival for patients. GOG 240 started this out in 2013 when this was reported by Dr. Tewari. And we had increased the median overall survival in frontline to 17 months. Now with immunotherapy, it's almost 3 years now. It can be up to 3 years with the combination of anti-VEGF and the PD-1 inhibition. So, if you're looking at either bevacizumab with Pembro or bevacizumab with atezolizumab in the BEAT-CC trial that this group participated in, and we've really hugely moved the needle, for these patients. This group brought on tisotumab vedotin, which was a salvage therapy that was effective and tolerable in a setting where there was really nothing to give, our patients. And so that we had a whole series of trials, which ended with TV301, the phase 3 trial, that really set that as the standard in this space. And then we moved immunotherapy all the way up to the locally advanced space. And you were an author on the New England Journal publication of Keynote 18. It was a huge advance forward. But, there's still work to be done in this space. I think, we had a lull after all of that work and the excitement of, wow, we've really sort of made huge progress. And I think it's easy to get sort of complacent, like this is, we're done here because it was such an improvement. But really, when you think about it, I feel like it's a middle ground. I think it's a middle step. I think we need more progress. And that's where this trial comes into play.
Yeah, it's so exciting. And we can see that, right? In our clinic, we see our patients and, they're doing so much better. We're having so many more wins. It's so nice to have options. Whereas before, once one of our patients had recurrent cervical cancer, there really wasn't a lot to offer. But you're right. We can still do better. So this trial, GOG 3101, TroFuse-20, would you mind, so this is sacituzumab deruxtecan, an ADC. Would you mind explaining the trial, the schema of the trial, just briefly the eligibility and the mechanism of action of the drug?
Yeah, sure. So the trial's simple. It's a phase 3 study in the second line only setting. So that's, a little restrictive, but it's just for patients who have whose disease has recently progressed on that Keynote 826 or GOG 240 regimen. And they're coming into that second line of therapy. It's unselected and it's a TROP2 ADC. So TROP2 is pretty ubiquitously expressed on cervical cancer, much like tissue factor was for tisotumab vedotin. So right now we're testing the marker, but we're not requiring the biomarker for enrollment. I see this the payload of sacituzumab is a camptothecin. It's a topotecan-like drug. So, I see this as a way of expanding um, a drug like TDXD to a general population. The anti-HER2 had such huge impact for HER2 positive patients, but cervix, there's not a lot of HER2 positivity. So really at the end of the day, that's a very restricted therapy in cervical cancer. So, this I see as a drug that broadens that eligibility for a topo payload to the general cervical cancer population. So that's why this trial is so important. We have preliminary data showing the activity of this drug even when given in combination with immunotherapy and IO treated patients, a 60% response rate in their current setting. So this is, a really important drug to be studying. And we're comparing it to physician's choice chemotherapy. So it's almost identical to the design of TV301 or Empower Cervix with cemiplimab in this setting. And the investigator's choice chemotherapies include tisotumab vedotin, which in the US really I would say is the standard in that setting. You can use other chemotherapies if for some reason they're not eligible for TV. But really in the United States, this will be sacituzumab versus tisotumab vedotin type of opportunity. And the
Thank
primary
you.
endpoint is overall survival and PFS.
Thank you. That was awesome. So I think you answered the next question, which is why is this a promising approach for
Mhm.
patients with cervical cancer? And, if you think about it, we're seeing antibody drug conjugates or ADCs across all types of cancers. And we already have one, like you said, approved for cervical cancer, but it has a different payload. And
Mhm.
so I think that's one of the things as an investigator that I find so attractive about this trial. So if I have a patient and maybe she's already recurred after she's had chemotherapy and immunotherapy, and I'm thinking about giving her tisotumab vedotin, but maybe I want her to have a chance for another line of therapy. You can always give that afterwards. So the clinical trial just makes sense because you say, all right, well, if I have the trial available, I'll offer her the trial. If she randomizes to standard of care, she'll get the tisotumab vedotin, like I was going to give her anyway, or maybe she'll have a chance to get another ADC. So that's exactly what you said, actually. So it's very important. What screening tips do you have for this trial? It's been, in the United States, it's very important that we have enrollment so our patients are represented um, as we're studying this drug. So, what tips do you have for our investigators?
Yeah, I think that's a great point. I mean, you've had this study open, right?
Right.
It is tricky to get you're trying to catch a tricky population at exactly the right moment. It can be difficult to catch them right at that second line. Some strategies. One I learned from you is monitor your patients who are on the Keynote 826 regimen because that's the patient population. If their disease progresses, you want to capture. Now you're always hoping that they're not going to progress,
Right.
like you're
Of
torn,
course.
right?
Yeah.
Right. And the funny thing is that like that strategy has been helpful but limited because patients are doing so well on that regimen. So we've been just kind of like watching and watching and watching and watching and they're doing well, which we love. So that is one strategy. And the second strategy is that this study, it's not biomarker restricted, but you do have to have tissue to get patients on trial. And we found that to be sort of the rate limiting step and getting our patients randomized to treatment. As you know, they need to get on treatment quickly. They can progress quickly. That's been sort of, a barrier. But if you work on that first, if you just say, okay, the tissue, we start at day one. Like we start looking for the tissue before we even consent the patient, because once they're consented, then we know where it is and we can get it. So that's really a trick. And then lastly, this is only open in about 30 sites across the country. So you may need to refer your patient out, like refer your patients. We'll give your patients back. We don't mind to give them back when they're ready for standard of care treatment. But you brought up such a great point. How do I decide, like, do I really want, do I want to put my patient just on standard of care TV, or do I want them to go on the trial and get randomized? At work, the worst thing that's going to happen is they're going to get tisotumab, right? And
Right.
then they have a chance, like you said, to get the ADC. The faster this trial gets done, the faster this drug is available in your clinic so that you can make that decision at home. So this is just a temporary situation that we have to sort of like, I'm use surgeons terminology, you got to suck it up and get it done. And then, we'll have access to this drug in the clinic. So that's really my motivation to get this move forward. I just want to see this drug available in more locations than just the study sites.
Agreed, agreed. So, final question. From a patient perspective, how can patients find out more about this trial? I think we're seeing our patients being self-advocates more and more. And I've had that. I've had some patients, come to see me because they heard about this trial, but where can patients look to find more information?
Yeah, I think that's why we're here today, right? More information is available on clinicaltrials.gov. This study is sponsored by Merck. It's highlighted on their website. It's also highlighted on our website. It can be hard to navigate those things as a patient, right? You have to sort it out from other information. You're not sure what all that means. I think this podcast is invaluable because, this goes up on YouTube, right? So this could be available to patients. This is in the public domain. Our study sites can push this podcast out from their social media pages. That's, compliant. Doesn't necessarily need to be IRB approved unless you would just have to check with your local institution if you need an IRB approval to push out this type of information that patients can connect with. The helpful thing about clinicaltrials.gov is it has the list of where the study's available. So you can pick the site, that's closest to you. They have contact information on the website, or you can just contact the GOG. We have on our website, we have contact emails. We look at those emails. We respond to those emails. If you're a patient and want to get placed into this trial, we can direct you to the site that's closest to you.
Thank you so much, Dr. Randall, for agreeing to join us for this podcast. And thank you to our sponsor, Merck, for their collaboration. And on a personal note, I've just really enjoyed working with you over the years. You're a role model for all of us, really, as far as everything that you've done for our patients with cervical cancer, with all of these trials. Shout out to all of our investigators and to our patients. This is an important trial. We're making progress. We need to keep up the momentum. Please, spread the word. All of this information is very important. Thank you so much.
Thank you. Thanks for having me. I became a G1 oncologist because of a cervical cancer patient. It's really special to be able to have these opportunities. So thank you so much for your work to highlight this. I think getting this information out in this way makes it so much more meaningful. So thank you.